Well, maybe we start with the economy opening back up. That's the first thing. So basically, you can't go forever without paying mortgage and putting food on the table. So people do have to get back to work, and that's one of the reasons that we've moved down what we call the COVID color cascade from red to orange, and then the governor, I think, announced at noon that he wants most of the state moving back to yellow, which means that more of us are going to be going back to work. Now, the reason that we've moved in that direction is that there is a plateau of the number of COVID cases we're seeing in the state. We've been very lucky, unlike some places like New York and Italy. We haven't seen that many COVID cases. And so the point is that we do need to kind of put things back towards normal as much as possible. So people are going to be going back to work. They're going to be trying to resume their lives as much as they can in the way that they were doing that before this hit. And then we move on to things like recreation and vacation. But actually, I think more importantly is how we begin to approach work, how we get back to work and stay safe. One of the things we are seeing in areas that have kind of gone back to work and people are congregating again and coming together is that we've seen a surge in cases of COVID. So we have to be ready for that, because once again, when people start gathering, then this is how this illness spreads. Hopefully that's not going to happen here to any great degree, but we need to be aware and we need to be ready to handle that. And there's a few ways to do that to make sure that we stay safe. It is true, the thing that is great about Utah so far is that we have a relatively low rate of COVID in the community. That runs about, based on our testing, probably between 3 and 5%. That's pretty low. You look at places like Italy or New York and it could be as high as 20%. That's pretty high.
Yeah, it's pretty amazing when you look at the testing results every day. Out of everybody that tests, only 4.5% generally test positive.
Right, so what that means is that a number of people have symptoms, but those are other problems. It could be allergies, it could be other viral colds that aren't a big deal, but 4.5% are COVID positive. But again, the point is if you go to a restaurant, your chance of becoming ill is not zero, but it's not high. It's somewhere in between.
Based on where we live here.
Just based on what the prevalence of this illness is in any particular community. If you live in rural communities, it's perhaps even lower, except if you maybe talk about San Juan County where there's a higher rate right now. So you need to be aware of that. So yes, to your point, if you're indoors in a restaurant, it's possible that you could have air circulated with COVID. There's a study out of Wuhan, actually another city in China, that looked at diners. There was one person that had COVID and a number of people in that restaurant became ill from COVID because of the air circulating. But the way that restaurateurs are setting up here again, and they do need to get back to work, is they're setting up outdoor tables, they're putting spacing 6 feet between patrons, and they're trying as best as they can to make sure that the environment is as safe as possible. And I think what the public needs to realize is that there is never a 100% chance that you will be safe at all times. And it's a new era that we're living in, at least for the next several months to maybe a year. We have to be used to some risk, but we also have to take precautions to make sure that we're as safe as reasonably possible. So being outside is safe. Being outside within 6 inches of people like you might be in a ballpark is probably not safe. Having a stadium, an open air stadium packed full of people, probably not that safe. Going to a Little League game where people are dispersed on the benches, probably pretty darn safe. Yeah. Running in a park, sitting in a park 6, 8 feet from each other, talking, safe. I think that's just fine. Outside is fine. There's probably only 1 or 2 instances of transmission to people outdoors that we know about. That doesn't mean there aren't other transmissions, but ones that have been documented. Transmission that's been documented basically occurs when people are tightly confined. Call centers, where people are talking on the phone, talking all the time and sitting cheek to cheek to cheek to cheek. That's where people, over long periods of time, that's how this illness spreads. It's not you and I sitting here talking for 10 minutes. It's not you and I running in a park and passing each other. It's not you and I being on an elevator going up and down. It's not that, generally speaking. Those risks are pretty low. It's being in contact in a confined space for a long period of time. So what we also know is that if we must be in tight confines like that, and sometimes you have to be, right? Okay, so if you have a job in a call center and they can't possibly rearrange the call center to spread people out, if they can't do that, then there are other things potentially you could do. Wear a mask and the mic under the mask perhaps. We do know that masks very significantly reduce the risk of transmission. Most of this illness is spread by droplets, whether people are talking for long periods of time or coughing or sneezing. And if you can reduce the spread of the droplets by using a mask, that really dramatically reduces the risk of infection. And the reason I mentioned before that it takes time, it takes long periods of time, is because most exhalation of people who have COVID doesn't contain virus, okay? It just doesn't have virus in it. So it's time, proximity, and the lack of protective equipment. It's a great question. Across the country, the zero visiting policy is very difficult on families and loved ones who want to visit. They're ill, and when people are in an intensive care unit, they are ill. They want to visit, they want to be there, they want to support the family member who's ill, and we understand that. The risk has been in a situation where COVID is circulating, that if a visitor comes into the hospital and moves about an intensive care unit with or without protective gear, that the illness could spread. And that's the major concern that we have and that all other health systems across the United States have had. Having said that, as the state and the nation moves down the COVID color scheme from red down towards green, we're going to reevaluate our visitor policy. So we're taking the time now between here and June 1st to rewrite or to rethink our visitor policy and to try to find ways that visitors can come to the bedside of their loved ones in an intensive care unit. I understand it, I appreciate it, I know how difficult this is. We are employing things like iPads that nurses can give patients so that they can communicate with their family members. This isn't always possible in an ICU setting, and I get that as well. So we're going to look at that again.
Have any of the visitor policies changed?
They haven't changed since
okay.
we set up the testing at the front of the hospital and instituted it.
Yeah.
So I say zero visitor policy, there are exceptions. End of life, of course. Deliveries, new babies, we have exceptions. And then for patients who are mentally having problems with cognition, they might be delirious, they might be confused, we allow family members under those situations. And then in cases like transplant surgery, we have exceptions for that. But beyond that, it's still a zero visitor policy. But again, we're going to relook at that and rewrite the policy. We'll have something new by June 1st. If someone does not want to be ventilated, we would honor that wish. If it was clearly defined, we would honor it. If a person was ventilated and then the family members believed that the wishes were such that the patient didn't want to be ventilated beyond a certain period of time, that would be a discussion between the family member or the legal guardian, and the outcome of that would be what the family would want as the representative of the patient. Outside barbecues, good idea compared to inside barbecues,
sure.
Right? So everybody wants to be outside during a barbecue. Again, respecting some of the physical distancing when possible, right? That is 6 feet, staying outside, nice sunshine, beautiful situation.
Is everybody wearing a mask in this scenario? Are we going to all have mask tan lines?
Well, we'll get to that in a second,
okay.
But let's just finish up with the barbecue piece. I think outside's certainly better than inside, and then cooked food, not a problem. Prepared food, you might want to think about prepared food in terms of being a vehicle for COVID. I think the chance is very low, but it is something to think about. Somebody else is handling the food, and especially if the food is not cooked.
Yeah.
So do you bring food? Do other people eat that food? I'm going to leave it to the audience to be as careful as they can. I'd say cook food, grill food, that's all right, that's fine.
Because the heat's killing that virus.
Yeah, absolutely. Yeah. Viruses are very delicate little things, and they don't last very long at all. But if it's on a moist surface, prepared salads, things like that, well, it's possible. So I wouldn't say it's zero.
We're not putting our hands in the chip bag. Should probably not have the communal chip bag anymore, or the chip bowl probably.
You could have individual chip
Yeah.
bowls. You have a little Susie's chip bowl, Bob's chip bowl,
Sure.
and you just pour it in there.
Okay,
So.
great.
Now, masks. Do I think that it would be wise for people to wear masks at gatherings where, let's say you got a backyard barbecue with 25 people? Yes. Wear masks. You're going to be crossing and be in basically fairly close contact from time to time throughout the 3-4 hour session that you're having a barbecue. It's probably a good idea,
Yeah.
you know?
Fewer numbers if you're not crossing.
Fewer
as much,
numbers,
then-
yeah. Be safe.
Yeah, just use your own judgment on that.
You know, it kind of goes back to what we were talking about with mask usage previously, that it really does prevent the spread of this illness. But again, being outside is also an extra added benefit. The homeless population has been disadvantaged, as most of us might imagine, because they don't have a place to dwell. And so when they become ill, how do we find a way to separate them from the rest of the homeless population that lives day to day, sometimes in shelters and on the street? And there is the ability in the county now to have housing for people who are COVID positive and homeless. The exact mechanism of how that takes place, I'm not aware of. The 4th Street Clinic and some of the shelters know how to do that. It is a very difficult problem because that is an underserved section of the population that doesn't have a lot of resources. It's difficult for them to stay isolated and separated. And because of the reasons that they're homeless also makes sometimes it's hard for them to maintain physical distance and maintain the right amount of time and space. It's tough. It's a really tough issue. But there, as I said, the county has arranged for a number of housing units, apartments, so that they can isolate. And again, if you want to know more about that, the shelters will know, as well as 4th Street Clinic will have an answer for you on that. Well, we don't know definitively by looking at antibody studies. If you're antibody positive, that means that you've been exposed to the COVID virus. We pretty much know that. Does that mean that you're going to be immune? We don't know that yet. We can maybe make that assumption, but that's not an assumption that I would tell a person. So I would not tell a patient of mine that tested positive for COVID, hey, go out and have a good time and hang out with people who are sick with COVID. I would not do that because your immunity is not proven yet, although we think it's probably a pretty good bet. I think in time we're going to know, and when I say in time, probably 2 to 3 months. We are asking that folks that are COVID positive with their antibodies maybe consider donating plasma, because that plasma could be used, convalescent plasma can be used to treat people who are very ill. And if we do enough of those studies and we find out that those patients recover quickly once they receive plasma from people who are antibody positive, then we could say, you know, very likely when you're antibody positive, you're immune. But we can't say that quite yet. We know with most other illnesses, viral illnesses, when you're antibody positive, you're generally immune. Immunity tends to last anywhere from months to a year. And then, of course, if the virus changes coats, like influenza, you won't remain immune. So right now, a positive antibody test doesn't guarantee your immunity, but we're thinking that we're hopeful that it probably will. The other thing is our community is probably not very high in terms of antibody positivity, so the vast majority of our population has not been exposed to this virus and therefore would not be immune to it. Herd immunity means that when enough people are antibody positive, and you know that that creates immunity, that you get to a level 40, 60, 70% of the population is positive, then those who are not positive are protected by being surrounded by people who are positive. So masks can be worn. So we have surgical masks, and I have a mask in the office, and I wear that every day. When I'm not talking to Scott, when I'm with other people. I wear that every day, and I wear it for a week, and then I change it out. Cloth masks, you can wash them when you are done at the end of the day or at the end of the week. The point about a mask is what we call source control. So the idea about wearing a mask is you protect others from yourself should you have the illness. That's what the mask is about. The mask is also helpful to prevent you from getting COVID from somebody else, but it's much more effective in preventing you, if you have COVID, from giving it to someone. I've heard case reports, and I can't speak much to this, but what I'm hearing is it causes what we call an autoimmune-like illness, which means your own immune system crosses over from attacking the COVID virus to attacking your own tissue. And I've heard that it affects arteries in children, but that's all I know about it. I think it's very early to know much about that. I think we'll know more in time. There are case reports about this happening around the world, but beyond that, I can't tell you. We see this with viral outbreaks, with influenza, with other types of viral outbreaks. You will see cases of autoimmunity where, for some reason, a particular person's immune system reacts to their own tissues after responding to the virus, and we don't know why. But it could be tough. It could be a bad thing.
When it comes to kids, at one point it was kind of believed that it's not affecting kids as much. They might be a carrier, but it's not really affecting. Is that still?
That's still true. This is an illness that if you look at the rate of hospitalization and then of course death, it's very, very low until you get to 50, and then it starts to rise. And by the time you're 80 years and older, it's 15% mortality, 10, 15, above 15%. So we don't exactly know why. With influenza in 1918, when they had the great pandemic, both ends of the spectrum, young, old, and and also people in the middle were impacted. So why this particular illness affects mostly people who are old in terms of hospitalizations, worse illness and death, I don't think we know. There's some theories out there now that are kind of interesting. They're kicking around that maybe people who've received live vaccines do better. They have less severe illness. So an example that I would put out is people who've had mumps, measles, and rubella vaccine. One of those is an attenuated or weakened live vaccine. If you look at the USS Roosevelt, where that's the ship, where there's a controversy about the captain who was kicked out of his role. He had to step down. There was one death out of 600 and some odd 68 sailors, but only 4 hospitalizations. Now the usual hospitalization rate is about 15%, not death, but hospitalization in that age group. We saw nothing like that out of that group. What was the difference? Well, first of all, they were healthy. The vast majority of the sailors were healthy. But they all received mumps, measles, and rubella vaccination on entrance to the Navy. That's part of the Armed Forces immunization program. And there's some other instances of people receiving tuberculosis vaccine where it's being looked at in Europe that those people seem to have a lower rate of hospitalization and death from COVID. It's an observation. It's being studied now. Is there something to live vaccines kicking up immunity in universal immunity in our bodies? We think that might be the case, but we don't know. Something to think about. You're talking about what is the infective dose, or how many virons do you have to breathe in order to become infected. It's different between different viruses. So measles and varicella, which causes chickenpox, you need very few virons to get sick. COVID, unclear. Some say 5,000, but we don't know for sure. And as I mentioned earlier, people breathing, most of the time they're not exhaling this virus apparently. So it's true that with this virus, you probably need significant contact over a long period of time to get the right number of virons that kicks the infection off. Your question about whether a massive dose would make you sicker than a smaller dose, I don't think we know that yet. There's discussion about it, but I don't think, we really don't know. Whether when you're infected, you're infected. If you're infected with more viruses initially than not, I don't know that we can say that it makes you sicker. I think there are probably other reasons that you become more ill that have to do with your age, whether you have diabetes or hypertension or some of these other things that patients have that they have when they end up in the hospital. I've heard about this. I can't answer the question. I've seen it. don't know enough about it to comment on it. Let's hope it's true.
Yeah, you lit up, man. You talked about
No, it's
stuff.
it's interesting. I mean,
knows his stuff.
okay, so what we didn't know yesterday, we maybe know a little bit more about today. We're going to know even more next week, and we're going to know a ton more in 3 to 4 months, right?
Yeah.
I mean, okay, we look at the vaccine trials, right? So usually from the time they start a trial to look at how to build and create and market and distribute a vaccine, it takes forever. So we've started with, since January, and NYU is the site of a phase 2 trial for one of the pharmaceutical companies starting a vaccine, phase 2 of a vaccine trial. That's unbelievable, how quickly we're moving to find out whether we have an effective vaccine. It usually takes years. So things are moving very quickly. And all this new information, like I was telling you about mumps, measles, and rubella, tuberculosis vaccine, now vitamin D, what's next? And then all of these things need to be looked at and studied. Most of the time, when you hear about it, these are associations made through epidemiologic work. Associations. Associations are not proof, so then you have to do the studies to show that it actually works. So going back to things like hydroxychloroquine and chloroquine, there was some discussion about whether that was effective. Now it seems maybe not so effective. It's still being studied. Those two drugs are still being studied. Will they turn out to be effective against COVID? Time will tell. But they're probably not the panacea they thought they might be initially. I don't think so, because I don't think there's any proof that that works. Now, if you want to take multivitamins orally, I think that's okay, that's fine. Once you start putting needles and making injections, there's always a little bit of a risk of infection, so I probably wouldn't do that.
But the underlying concept of doing things to keep your immune system strong, eating well, exercising, getting enough sleep, that helps, doesn't it?
I think it does. I think what really helps is what we talked about before.
Sure. Your behaviors.
Behaviors, physical distancing. So let me go back and just, some people do need to take vitamin B12 injections because they can't absorb it orally. And then there are some other more rare cases of people needing an injection of vitamins. But beyond that, you can take vitamins orally and get the same effect. It's a delicate little virus.
Yes.
It's frail. It falls apart. It doesn't work in the water. Now, one of the viruses that was a scourge of many people, you'll remember, was polio. And polio was a virus that existed in water.
Oh,
That's not the case with this virus that we know about. Wrestling in high school, right? I mean, that's a very close contact sport, or
I'm thinking like
contact.
soccer, baseball.
Yeah, I think baseball. That's a great one. You're pretty separated when you're playing. It seems quite reasonably, and people want to get back to playing sports. You know what? I think we just need to be aware of the risks, understand where we are in the color schema of COVID color as we go down to green, and go out and have fun. And I think some parents are going to be have a difficult emotional time having their children go back to close contact in sporting environments. On the other hand, we've got, the idea for me of not being able to work out or be outside and do things outside, that's a really tough trade-off. Eventually being inside and not being active is as bad perhaps as being outside and working out and being at a little bit higher risk.
Yeah.
So, again, I don't have a perfect answer for that. And
Really?
I don't want to tell people, don't go run track and don't go play soccer. I guess I might say, well, if the prevalence in the community was 30%, I'd say we probably ought to stay indoors and close the shutters and stay in bed. But where we are now, I don't think so. I think we go out and try to live our lives as best we can and try to get back to doing some of the things we were doing. Antibody testing is more and more available with a physician's order or nurse practitioner's order. You can get an antibody test. How meaningful it is, we talked about that a little bit before. The community rate is still pretty low. I am not sure that it is that meaningful right now. That is to say, maybe if you believe that it gives you some sense of security, that you're positive that you might have had this infection, by all means get the test. I can't sit here and tell you with 100% accuracy that you're going to be immune. But I think for a lot of people, knowing that they had COVID through an antibody test would make them feel a lot better about things, and I'm okay with that.
And antibody tests is still kind of the Wild West as far as that's concerned. There's a lot of different antibody tests that exist, and some are better than others.
Yeah, that's true. That's true. Of course, I'll say the one that comes from AREP is actually it's really quite good. It's very sensitive and specific, and it's a very good test.
Not as many false
No,
positives or
not at
negatives
all.
as
No,
perhaps
it's
other tests.
yeah. If you're positive, you're positive. If you're negative, you're definitely negative. So
All right.
I think it's quite a good test.
Dr.
So
Miller?
again, serology. What I would say is if you develop symptoms, go get tested. Get the PCR test. Get the actual COVID virus test. If you feel sick, you have concerns about being sick, go get tested. Go get tested. Because if you're negative, that's going to give you a pretty good sense of security and you'll recover, do okay.